Arthroscopic assisted HemiCAP insertion for large engaging Hill-Sachs lesions. The purpose of this project is to assess the use of HemiCAP implants for engaging Hill-Sachs lesions. This has been used as an alternative in our practice for the past 5 years for non-anatomical reconstructions for Hill-Sachs lesions. An engaging lesion was described by Burkhardt in 2000 as a Hill-Sachs defect that would engage the glenoid in a normal functional range. The implication of this is a high failure rate when unaddressed for a simple arthroscopic Bankart repair. The goal therefore is to provide a secondary restraint for catastrophic failure of our Bankart repair. We aim simply to fill the medial to lateral defect and not the superior to inferior defect. We therefore, by doing this, minimise the articular cartilage loss. This is not a load-bearing implant and should be recessed slightly on the articular margin. Preoperative planning is essential. We prefer a 3D CT arthrogram for assessment of these lesions. We can accurately size the Hill-Sachs lesion as well as using the arthrogram to assess any soft tissue deformity as well as the cuff insertion for accurate measurement of the Hill-Sachs lesion. Yamamoto in 2007 introduced the glenoid tract concept. He essentially looked at the way the humerus tracked along the glenoid in various degrees of abduction with external rotation. We can see this here in these diagrams. The essence of his project was that if a Hill-Sachs lesion was greater than 84% of the existing glenoid, then it was likely to induce failure with a simple Bankart lesion alone. We can see here in this axial view of our CT arthrogram the Bankart lesion as well as the size of the Hill-Sachs defect. If one is using MRI scan and including the labral and articular cartilage, we can see how it is easy to undercall the size of the Hill-Sachs lesion. CT arthrogram is therefore a fairly accurate way in assessing this. There are various non-anatomical reconstructions for a Hill-Sachs lesion which are fairly effective. The Latarjet-Bristow procedure is one of these procedures. It does, however, question the need to extend the glenoid if there is no glenoid bone loss. The remplissage procedure and the arthroscopic variation described by Eugene Wolfe are a very nice way of addressing this defect. The potential downside, however, is ongoing discomfort from posterior capsular tightness, as well as some reports of reduced excursion secondary to the tenodesis effect. We can see how this is an effective restraint. However, the imbrication of the posterior cuff into the Hill-Sachs lesion can potentially reduce our excursion and external rotation. The goal, therefore, of the HemiCAP is to provide an implant which can partially fill the Hill-Sachs lesion and provide a normal excursion throughout the arc of rotation. The defects we are discussing are preferably 20 mm medial to laterally. If we have a long elongated defect, we tend to stack the HemiCAPs as seen in this X-ray, one superior and one inferior. We can also combine this with anterior bone grafting if the Hill-Sachs lesions are extensive. Setup is obviously critical. Although we have not used the 70-degree arthroscope, we feel that this would be a good adjunct to this technique. We tend to prefer to use the lateral position as the high anterior portal based on the glenoid is useful for looking down the line of the Hill-Sachs lesion. An arm holder with the ability to rotate the humerus is also essential, as is a low flow plump. We can see here the use of the spinal arm positioner with its ability to rotate the humerus as well as allow the arm to be in various degrees of abduction. This photograph shows a Hill-Sachs lesion as addressed through a formal posterior approach. We generally use the interval between the infraspinatus and the teres minor. However, the infraspinatus itself can be split. We simply are aiming to fill the defect medial to laterally. The lesion is then drilled down to the appropriate depth. It is tapped before the screw is inserted. The defect is then trialled before the HemiCAP is inserted. It should be pointed out that we can always seat the screw further if it is slightly proud. One, however, can see if we view the HemiCAP at 90 degrees, we get a much better perspective on the depth of the implant. This is the advantage of the arthroscopic assisted technique, which we'll now describe. Here we can see a large engaging Hill-Sachs lesion. This is the left shoulder, and we're viewing through a posterior portal. The assistant is partially dislocating the shoulder to get this view. We also have a large superior labral detachment with a type 4 slap tear. And we can see a fairly typical anterior Bankart lesion. We're now looking through the high anterior viewing portal. Our assistant again dislocates the shoulder to aid our view, and we debride the base of the Hill-Sachs lesion. By using a calibrated needle, such as this cut-down epidural needle, we can get a rough idea of the medial to lateral dimensions of the Hill-Sachs lesion. The needle is then placed through the posterior portal to assess that we're 90 degrees to the Hill-Sachs lesion. The arm can be rotated to maximise this view. A 2 to 3 centimetre incision is then made in the skin, and the deltoid is split in the line of its fibres. With blunt dissection, we can dissect the deltoid away from the posterior rotator cuff. The posterior interval is then visualised before being split in the line of its fibres. A single Langenbach retractor can be placed inside the capsule. We can use 2 retractors as seen here, however there is a large amount of fluid that escapes. By using one retractor, we can simply slide our instruments along the length of the retractor, and with no instruments in the shoulder, the capsular flap closes to prevent fluid escape. We position the HemiCAP sizer in the mid portion of the defect. If we're doing 2 HemiCAP implants, we do the inferior one first. This prevents our view being obscured by having a superior cap in place. We then drill before tapping to the appropriate depth. We insert our screw. We trial to see that we are at the appropriate depth with a slight recess. We score the edges of articular margins. The router is very carefully introduced so it does not destroy the posterior capsule and rotator cuff. A retractor can be inserted through an anterior portal to push the rotator cuff out of the way. Any excess debris is then removed. Before the HemiCAP implant is inserted. This is securely impacted into place. We now visualise the HemiCAP through a posterior portal. We then go on to perform a fairly standard Bankart repair, and in this patient, a biceps tenodesis. Post-operative x-rays show the 20mm implant inserted. This is a scapular Y view. An AP view, which also indicates the level of the biceps tenodesis. This is a photo of the patient at 3 months showing the scar from the insertion of the HemiCAP. We can also see the patient's external rotation and abduction. When we have longer defects, we tend to stack the HemiCAPs. Traditionally, we use a 20mm 20mm inferior HemiCAP and a 15mm HemiCAP superiorly. As we mentioned previously, we use the inferior HemiCAP first and then externally rotate the humerus to insert the second HemiCAP. We therefore can use the same skin incision. If there is both glenoid bone loss and a large Hill Sachs, we determine the combined width of the planned glenoid coracoid reconstruction. If the Hill Sachs width is still more than 84% of this combined reconstruction, then a HemiCAP is inserted. This is a case of a 23-year-old male who was dislocating his shoulder in his sleep. We can see a massive Hill Sachs lesion with no glenoid bone loss. A Latarjet procedure was therefore planned to reduce the Yamamoto ratio before insertion of 2 HemiCAPs. This is the post-operative X-ray, which shows a 25 and a 20mm HemiCAP inserted into the defect, as well as a Latarjet procedure. Previously, we were repairing the capsule between the glenoid and the Latarjet with metal anchors, as we can see here. In large unsupported defects, as we can see in this reverse Hill Sachs lesion, we're using iliac crest to fill the defect. The screw goes through the iliac crest into the host humerus before the HemiCAP is inserted. This is a 30mm HemiCAP used for such purposes. We can see the headless compression screws are used to secure the iliac crest. In this particular patient, due to the severe soft tissue stripping of the posterior part of the glenoid, a second iliac crest graft was used to extend the radius of curvature of the glenoid. A parachute technique has been used to restore the greater tuberosity and superior cuff. These are post-operative CT scans and X-rays at 2 years. There is no loosening around the peg of the HemiCAP. To summarise, this is a technique we've been using in our practice for the past 5 years. We have 25 cases to date. 2 of the failures have both been traumatic in nature. These were converted, 1 to an arthroscopic and 2 to an open Latarjet procedure. We found this therefore to be a reasonably reliable technique in combination with a Bankart repair or also with other procedures to restore congruity of the glenohumeral joint. Thank you.